Okay, we have a good 25 minutes for what will be a panel discussion. I gave everybody a heads up that courage was going to be something that would be required, and I think hearing those stories, we realize that we are talking about sometimes horrifically difficult situations, and our job is to figure out how to make them not happen. Let me just start with, if both of you don't mind, me asking the panelists what we would ideally like to see happen to have changed both of those stories in positive ways. I think about Maddie and the psychosocial needs that you see. Lori, do you mind talking, like, what should we have been doing to be able to get into that room and be able to reach out to both the family and to that boy about all of these feelings of, I'm not able to be part of my social peer group, I'm in tremendous pain, etc.
I wish that I didn't know.
Yeah, you have to turn on the mic and then pull it close to you. Yep, beep it right there in the middle.
I wish I would have known Maddie. I truly do. I think what it sounded like is that his experience was not being validated. And there really is no way back from that. So if a child is telling you they feel ugly, or they're telling you they feel like they're dying, or they're telling you that they're in pain, and that's not being validated by the staff who's taking care of you, beyond that being unacceptable, but how isolating and lonely for the child, as well as how frightening for the parents to feel so lonely in that experience. So there's so many different ways and different staff members that may be able to reach out to somebody like Maddie. Every child is different. Some are going to connect with the social worker. Some are going to check with the child life therapist. Some are going to have a nurse that they're going to, be attached to. It's finding a person who's able to reach him, to validate his experience, and to make sure that his needs are heard by the whole staff, and that there is staff meetings to be able to work as a team to make sure that his care is much more optimal than what you described.
I also hear how sort of unacceptable that standard of care is, and just to add to what Lori said, I think in general, if we had systematic ways to evaluate, ensure on a regular basis that the child's voice is heard through whatever mechanisms work, and we need to sort of better understand the best strategies, then we could have targeted interventions, because one size doesn't fit all. And no matter how robust our clinical services are, we need to get to a point of a higher level of sophistication where we're actually tailoring our interventions based on high quality assessments.
I think another point I'll just throw in there, I think, Gavin, you sort of hit on this, the variability in care, that we can do this better. It's not just a theoretical or hypothetical, that we already have places and people who are doing much better with this. How do we make that a uniform standard, not just a, boy, you were lucky that you got it, and other people don't? So I think that's a key part of that. How did you folks learn, and this is a tough question, I hope it's okay, that when the course of therapy pivoted from being disease-directed and let's try to get this to be cured to the prognostic information that Jenny was talking about, I'm curious a little bit to hear what you think should be done there as well. Was that being done well, or was that also part of what was in need of improvement?
So, Chris, are you talking about how we learned that Maddie's situation was going to be an end-of-life situation?
Yes.
Okay, well, that's a complicated story. It wasn't conveyed to us in a typical manner, because what I later found out is that there are certain protocols within the hospital that should have been happening. That's not exactly how it happened. So Typically, what I later found out is that one of the HEMONC doctors, according to protocol, would have told us that, based on what was transpiring, that Maddie's situation would have been, terminal, and then we would have proceeded with some sort of end-of-life care. That's not exactly what happened. I don't know if it was just a matter of the fact that everyone became so invested in curative intent with Maddie that it was hard to address these issues with us. And so how we found out is one day I was walking in the hospital rose garden, and one of the nurses that I was really fond of came up to me, and she said to me, "Vicki, Maddie is dying. I want you to know that." And I said, "I have no idea." And she says, "They don't want to tell you this, but that's what's happening, and you need to start making you have to start making appropriate decisions, because that's not the way the care is going to progress unless you start making those decisions." So that kind of communication was earth-shattering to me, because I wasn't expecting that. But in terms of Jenny's point, when the communication happened, when it was open and honest, it does change the direction of how the care goes.
And what was leading up to that was he had been 4 or 5 weeks off of chemotherapy, and he was complaining of stomach pain. And so he was reporting a lot of difficulty, and we weren't, in essence, being believed. And it was through Vicki and myself just pushing and pushing and pushing to us finally getting a scan to basically confirm what we already knew or highly suspected, was that his cancer had metastasized. So even just the frustration of those weeks of trying to get appropriate care, because Maddie was reporting it, we were seeing it, but we weren't quite being listened to. Back to the patient-reported outcomes and things like that, that conversation earlier today, it got to the point, it was August 5th, 2009, I remember the day, when the conversation turned from, we now need to stop talking about curative and start talking about how to make him comfortable. And that's quite literally almost verbatim how it was delivered to us. And we just looked at it and said, what does that mean? So delivery of that message in the communication is something that everyone should be prepared for, aware of, not necessarily responsible for delivering, but that surrounds the whole patient-family experience.
That part of our story actually was not as traumatic as the end-of-life piece. The day you're told that the fight's over and you're going home is always traumatic, don't get me wrong, but I remember very vividly we were in New York, and we were trying sort of a last-ditch effort to control my son's CNS disease, and he had a scan, and you can tell if you've been around hospitals long enough when the news isn't good, right? People don't look you in the eye, and all that sort of thing. So we had a sense that things weren't good, and we got called back to sit down with the head of the neuroblastoma practice there. And he came in, I'll never forget this, he came in and he walked right over to me. I was sitting down, and he walked right over to me and he gave me a big hug. And I knew what that meant. And then he hugged Wendy, and he had the conversation with us. And then he made sure to pick up the phone and call down here to Children's National after we had, said we want to do this down here, and that started the conversation collectively amongst all of us, including our colleagues at CHOP, that we wanted to do this at home here locally. So at least that part of it, I don't think back or look back at that in anger, because I think to the best of everyone's ability, they handled that fairly well.
So Jenny, how would we help providers be able to do this pivot of having a disease-focused type of conversation, and then is it that they pivot, or are they right from the get-go really making it clear to parents that they will be forthright and tell them about the things that they're potentially even going to be worried about? I mean, what are your recommendations to try to preemptively either train people or not have this prognostic delay in disclosure?
Honestly, I think that you've all said it so much better than I could. I think hearing these experiences is so powerful, and that the work that that you've done in teaching residents, and that's so important. You know, I think that that's a wonderful thing. I think that one of the things we have to learn to do as clinicians is inhabit these spaces that are very uncomfortable and sit in them and you know, be with families in them. And it's not easy to do. We don't want to do it. And so I think that that's the issue. You know, helping good clinicians, good people, learn to be in those uncomfortable spaces so that they can help do the right thing for families is probably the best thing we can do.
And I think I come back to this word, courage and compassion, and how to ultimately give that hug of, I wish I could do more for you, but I promised I'd be straightforward. Those scans aren't showing us what we had hoped for. I want to make sure we have time for questions, but I want to go back to the issue about pain, and particularly your experience with Evan at home. I'll ask Joanne a question in a second. I do want to say that medications matter, pain medications. The number of times that we are asked to do palliative care consults and can improve pain management by using the available medicines more skillfully, that's at least half the time, but I am humbled by the number of times where we do go in with advanced solid tumors and other, where we are really trying to figure out how to control suffering, and frankly our knowledge base and the availability of medications that we would like to be able to use is restricted by formulary restrictions or other things. So as we talk about medications not being the only focus, I think there is a focus on palliative symptom reduction medications, and we need a lot more of that. But Joanne, you talked about workforce issues. I'm sure we work down in the Philly area with lots of hospices where we struggle and usually succeed in providing high quality care. What are we going to need to do to prevent stories like what happened with Evan?
You know, again, I'm almost speechless to hear your story and your family story, because, and I was asking Rebecca, you know, how long ago did that happen? It's 4 years ago, and that feels so recent still, because I wish we had the systems in place to prevent anything remotely close to what you experienced. I do know, however, that there are models emerging around the country about how to better integrate pediatric expertise through hospice programs delivering care in home, which it turns out to be the highest, sort of most common place, albeit the hospital is also a common place where families want to reside at the end of their child's life. And those models need to be evaluated. Again, we sort of get back to not making assumptions about what's the best approach. It needs to be individualized, but we need to know what the menu of options is in order to be able to tailor it to an individual family. In Massachusetts, we have, through a legislative effort, a statewide pediatric palliative care program that embeds pediatric teams within hospice programs throughout the state. And that's one state solution which, from what I can tell, although we need to evaluate it further, has really raised the bar in terms of access to home-based palliative care. And then there are a number of other states like California and Florida that have Medicaid waiver programs that enable sort of enhanced pediatric palliative care in the home setting. So we're beginning to think systematically about how to raise the bar, recognizing that though the numbers are small, the ripple effect is vast, and that we need these home-based programs to be able to take care of our children in the highest possible quality. So we're still working on the solutions.
Yeah, Sarah Freebird, if you just raise your hand just for a second. Sarah has worked actually at formulating standards of care in the hospice setting, so that these are stories that haunt me, even to hear it third hand. That's what we need to solve. Now, I'm going to go to questions from the audience, and I think we start over here.
Hi, Larry Wolf from Cohen Children's Medical Center in Long Island. Many years ago, a colleague of mine by the name of Michael Goldberg, he's actually, ironically, I guess, an orthopedic surgeon, commented about, and he actually published this in the literature, about how the mission of hospitals used to be kindness, and that mission had, in fact, dropped off. And as a result, many of the trainees we created were not imbued in a sense of duty and responsibility around kindness. And I think we've seen today evidence of that. I think the thing that concerns me the most is that I don't see our educational programs moving in the right direction. And I have to point out that we have a tremendously rich body of evidence done by the people sitting at this table. I mean, it's extraordinary how much information we have. It's a little bit horrifying, frankly, because they've kind of torn the curtain away so that we get to see how much suffering there really is. And yet our response to that is, to a certain extent, kind of analysis paralysis. It's sort of like, oh yeah, this is happening, oh yeah, this is happening, but we don't have the money, they won't give us grants, they won't do this and they won't do that.
Well, if I can, Joanne, do you mind talking about some of the educational initiatives? Particularly, I'm thinking about EPIC, because I think that this is a very important issue, but there are efforts going on for the training, the trainers.
I didn't mention EPIC, and I'm happy to. EPIC Pediatrics is a train the trainer curriculum. I think you heard me mention it probably very briefly in my talk, and I didn't know if you got to your question yet, or.
Well, yeah, because I think EPIC's late.
Yeah.
The point I'm trying to make is that EPIC is late. You have to teach kindness real early, okay? I don't want a single physician to graduate from medical school who would do to those families what the doctors that worked with them did.
Yeah.
Okay? And I don't think that although there are some medical schools that have somewhat creative approaches to this, the vast majority of them within their professionalism units and within their relationship and communication units aren't even reaching a vestigial level of communication. And I think that when you have this body of research showing failure in communication, I mean, it's a brilliant body of research, that to expect that you can teach this after people have become somewhat differentiated and I might say hardened by their resident experience, I think it's late in the game. And I think as I look at what's going on, I'm afraid that all the champions in this room are going to kind of, you know, eventually grow old and leave the field. And I don't know who's coming up.
We hear the call, and I couldn't agree with you more.
And we totally agree. Over here?
Jonathan Hagan, Peter, Vicky, Wendy, Gavin. Our experience was similar in the beginning. So our daughter was very young when she was diagnosed with DIPG. Terminal upon diagnosis. Thankfully, her treatment team didn't take hope away from us and told us to always have hope, which I think is very important. And you know, there was some discussion about hope. Don't ever take hope away from your patients. Be honest, be open, but you have to be able to get out of bed every single day as a parent and take care of your child. When it came time for hospice to be called in for us, it was after an acute event, a severe bleed, and we didn't know whether our daughter would be alive for a day, an hour, or a week. That was October 10th, 2010. She was released back to home, and we made the decision that we wanted to be at home. That was where we were most comfortable. Initially, we had an adult nurse, and we had adult nurses around the clock for the first couple of weeks. And then she stabilized. The doctor came in here and there. But we kept hearing from other families around the country that their child got massage therapy, their child got OT, art therapy, various services that we then had to continue to ask if our child was eligible to receive or if they had these services. Thankfully, our nurse went on vacation, and they hired another nurse who was, in fact, a pediatric nurse, and everything was great after that. We had a much different experience from that time on. But they then looked to us to help create a pediatric program for them. And, you know, it is just inconceivable. In this region, in Washington, D.C., we live in Virginia. It's right across the river. It's inconceivable that there isn't that level of care available for children with cancer. You've got Children's National and NIH here, two of the top facilities around. So, you know, I commend everything that you guys are doing to push this to the forefront. I knew you guys had awful stories. I don't think I've ever actually heard either one of your stories specifically. So, you know, when you say, I don't want to hear there's no funding, I don't want to hear there's no grants, I don't want to hear there's no time, I agree. You know, that isn't helpful to a parent who is facing losing their child tomorrow or the week after. So from the right side of the table, as I'm looking at my right, your left, you know, you have a lot of work to do. I have so many questions in terms of how are you going to do it? But you know, you're charged with the mission of trying to help these families make sure their children don't suffer in the end of days. You know, this is more of a comment than anything else. But you know, where do you see it? Do you see standardization on the horizon, either from a legislative perspective or from a insurance perspective? Where do you see the standardization to ensure that hospice programs in this country have at least some basic level of standardization so that those stories aren't repeated?
Do you want to go first?
Yeah, let me just say a quick comment, and thank you, Jonathan, for your words. I think what you've heard today speaks a lot to the importance not only of quality care, but it speaks a lot to the importance of transparency and honesty. So if we were in a situation where we were told that, hey, we don't think, we being the nurses or the doctor, that we're going to be able to do what your son requires or do what you would like done for your son or care for anything unanticipated that might come up, which I would imagine frequently happens in our situation, that would have been a totally different set of circumstances, because we would have made a decision at that point. That conversation never took place, which only increases my anger tenfold. So I don't know if it was ego, if it was false confidence, if it was a combination of those things, but the fact that we weren't given the opportunity to have that honest dialogue makes things even worse in our view. So I think being able to provide the care and the services that these kids need obviously is job one, but if you can't, be honest and be transparent, and no one's ever going to fault you for that.
Chris, can I say one thing?
Yeah.
John, to follow up on your question, thanks for asking it. Standardization. We all know there's a medical standard of care. There's not a psychosocial standard of care or palliative supportive care. So that is our objective. And the question is adoption. How do you get it? Well, there's a stick and a carrot routine. The stick is you go to the federal government and you say, this is essential care, mandate it. And that would help on the CMS front, Centers for Medicare and Medicaid, because they cover a lot of lives and they deliver a lot of care, particularly in the pediatric space. So make the federal government deem it essential through the evidence-based data that we've collected and proven that this is the standard of care and must be delivered. Therefore, that handles that population. Then you start going at the accreditation entities that deliver the majority of the care. The adult world did it in psychosocial care, and Paul Jacobson, wherever you are, congratulations for all that hard work, because now to get reaccredited in the American College of Cardiac Surgeons, you must screen for psychosocial distress. So, sure, it may not be the be-all, end-all, but it's a great first step to get it integrated. So those are the two ways, in my opinion. And then eventually the private insurance companies will eventually have to adhere. But I think first, federal government and through the accrediting bodies, you will then start to mandate that.
A three-pronged strategy. You have to have boots on the ground. You have to have people who can actually provide the care. They have to know what they're doing. We have to be able to refine what they're doing for these problematic, like, okay, how do we get this kid out of pain, the really tough cases. And then we have to have standards. And we're pushing all of them. I think in the last 10 years, we've come a long way. But we are very, very aware that it is a patchy coverage, and we still have a lot of room to grow.
And I'll just add that we are doing so without money. So imagine what we could do with a little bit more money. Not that we're going to ask for it, because I hear that, but it's been quite a movement and quite a growth. We're far from where we need to be.
Well, don't misdrew my comment. My comment was you should ask repetitively, and the onus is on the responders to provide you with what you need, whether that's the government, private foundations, whomever. It's too important not to be supported.
I just add, in terms of transparency, a child should never be told they can go home with hospice care if they do not have a pediatric provider. Just no. It's just not acceptable.
Lindberghs and Browns, thank you for your courage in sharing your stories. And like everybody in this room, I'm horrified that it's amazing to me that this still happens in the United States. And I don't think it was those people who failed you. I think it was our system that failed you. And that's what this is all about. So hopefully things will come out of here that will make sure that other families don't go through this. But the one thing that I haven't heard us talk about is empowerment. And why aren't we, don't we need to tell these families, you don't have to accept this? Now, I know that's hard at end of life, but it certainly isn't hard if you're not getting the right pain medicine during treatment. Parents and families shouldn't be accepting this. And so one of our challenges may be, how do we empower them? So I'll ask that of you.
Yeah, I think it is a challenge, and it's particularly a challenge when you're in the fog of the situation. You're not doing anything probably the way that you should when you're in those last 2 weeks. You're lucky to make it through each day. So relying on parents to provide that care, I think it's not the best way to go.
Pain during treatment when you do have time, certainly once
Yeah.
you're in that, I understand.
Yeah.
I couldn't agree with you more. Part of our work was sort of around this feedback of child-reported symptom distress and quality of life outcomes. And from a parent perspective, the ratings around that feedback report were incredibly high, and sort of the bottom line was, now we know how our child is feeling. So that's number one, even sort of getting them to understand their child's experience. But the other is that we are complacent. As providers and as families, we expect that because they're getting cancer treatment, they have to experience all this distress. We haven't challenged ourselves to raise the bar and to raise parent expectations that we can do better. We don't even know how much better we can do until we set out that as a goal. Whether or not symptoms should be an outcome, I believe it is. It counts for the experience right now. There are also more distal outcomes that are really important, but that collectively feeds into how a child and family emerges from this experience. And so absolutely we need to raise that bar.
I just wanted to respond to the empowerment point, because I think that's a really excellent point. And I think the empowerment is really tied quite well with communication. And I think if Peter and I were told along the way, through the trajectory of how Maddie was doing, because there were lots of ups and downs, more downs than ups, and it just kept going down, down, down along the trajectory. But I think what would happen is, with more open communication, primarily, and I'm talking from physicians, so please don't think I'm talking about his psychosocial staff. I'm primarily talking about physicians. So if I understood, and Peter understood, what his medical trajectory was, then I would have felt more empowered as a parent to make better decisions for him. And I found out, once I found out that we were dealing with end-of-life care, then I did have hope. Getting to Jonathan's point, you do have hope changes along the continuum. Yeah, it may not have been hope for a cure, because that went out the window, and then the hope changes. Hope for maybe a more sound and painful death. Get right, a humane death. And so you can become empowered when you have data and you have information, but that needs to be communicated to you. So empowerment and communication, they go hand in hand.
I would just add that we're talking about empowerment mostly here towards the end of life or the last 2 weeks, and that's way too late. I mean, early on, families should have conversations with their provider. How would you like to receive information? Some are more auditory learners, some are more visual learners. Start that conversation really early on. We're going to keep you informed. How do you like to have this conversation, or to be able to learn this information? Questions that you could be able to go back and revisit. I hope that your child does well, but in the case, he or she doesn't do well, these are things I'd like you just to be able to think about, so that if you do have a relapse, you could be able to revisit that conversation. It's not hounding on it, but it's really empowering them to be able to get the information in the way they could best learn it. And just one other point, sometimes it's really the child that gets empowered, and when the child becomes empowered, they really help empower their parents.
Okay, we took a deep dive. I would hold on to all of the, I think, quite righteous and rightful anger and pain of what people go through. At the same time, take a breath, because we've run to the end of our session. I want to thank everybody who's participated, because in this, there's a lot that we can do that's very powerful and good. So thank you all. We take a break now.